Hi, good evening, everyone. Welcome back to the living room. I'm so happy to see a full house. I'm once again so sorry it's so hot in here. I promise we're gonna try to work on that for next month. Welcome, welcome, welcome. We're really excited about tonight and the speakers we have. As most of you know, because you've received our emails and or seen the Facebook posts we've been putting out, we have Dr. Larry Heifetz here from Gene Upshaw Memorial Tahoe Cancer Center, which is a mouthful, and Dr. David Gandara from UC Davis Comprehensive Cancer Center, both of whom have spoken at the living room before, so we're really, really appreciative and grateful to have them back. There's a lot of faces. I see some travelers in the room. We've got Sacramento, San Diego, so thank you all for making the trip to come down, and a lot of new faces in the room tonight, so welcome. We're going to start with our around the room for those that want to introduce themselves. I will ask, because of the crowd, that we keep it to date of diagnosis and type. That would be great. So just when you were diagnosed and what you were diagnosed with. And then that way we can have plenty of time for the presentation and for some Q&A with these great docs. So I don't know if the Bassos want to start.
Hi, I'm Mary, and I was diagnosed with non-small cell lung cancer in 2010, October 2010.
Close to the lips.
Hi, I'm Wells Whitney. I was diagnosed also with non-small cell lung cancer, but it was in 1998. I was stage 4. I'm still here, still coming to the living room. I'm a co-founder with Bonnie of this wonderful foundation. I've been to Living Room many times, and I just love the venue. Thank you.
You don't have to. It's yeah.
Hi, I'm Elaine Gray, and I was diagnosed May 4, 2008. And I have stage 4 lung cancer, and I'm doing very well.
Hi, I'm Sally, and I was diagnosed in February of 2009's non-small cell adenocarcinoma, and very lucky to have stage 1A.
They have a mic. They have one.
We're all turning off our cell phones now.
I'm Rosemary, and I was diagnosed June 2013 with adenocarcinoma.
My name's Tina, and I was diagnosed November 2010 with non-small cell adenocarcinoma, stage 3B.
Hi, I'm Neil. I was diagnosed just over 3 years ago with non-small cell lung cancer, stage 5, adenocarcinoma, the EGFR mutation, then the next one, the T790M, now the new one, the BS22, hasn't been discovered yet, but it's in there somewhere. I am, as always, a foremost advocate for this foundation, and as part of that also, always pushing everybody to please look at available clinical trials. Only 3 to 4% of the people participate. We are what they want. So look at it, see what's around, check it out every couple of weeks, find out what's available for you, ask some questions. You know, everything that we're taking now came from the trials 5, 10, 15, 20 years ago. There won't be new medication unless we're the experimentees. So please, take a look.
Nice.
Hi, I'm Chrissy Harrison, and I was diagnosed just this last February with non-small cell lung cancer, stage 4. And it has, it had spread to my lymph nodes and sternum. However, at this point, the chemo is working. My major lung tumor has been reduced by to about 5/8 of where it was. And the tumors in my lymph nodes are now undetectable. So I'm sticking with the chemo for right now, but, only because it's working. We'll do another CAT scan at the end of July, and we'll see what's happening then. I'd like to think that it's just going to keep going in the direction it's going, and I won't have to come see you guys ever again. Thanks.
Thank you.
Hi, my name is Joyce. I was diagnosed in December 2011 with non-small cell lung cancer adenocarcinoma. Diagnosis did change when I had a progression a couple of years later. So right now my diagnosis is large cell neuroendocrine carcinoma and stage 4.
Hi, my name's Doug, and I was diagnosed last Wednesday with non-small cell lung cancer. I'm not sure how you say this, adenocarcinoma.
You can say it any way you want to say it.
Okay, so I'm new to this and still very stressed, so I'm hoping to benefit from the group.
Back row people. I think that we've got a mic back there for anybody. There we go.
Hi, I'm Diane Broderick, and I was diagnosed in November with adenocarcinoma stage 4, and I have a PIK3 mutation.
Anybody? There's, yeah, to...
Hi, everyone. My name is Enrique Martinez. I was recently diagnosed on February this year with lung cancer stage 4. I just finished a couple of weeks ago the first phase of my chemo treatment, and I'm supposed to go to the next stage will be a treatment. For now, I hope, because tomorrow I'm going to get another biopsy to get more tests and the mutation tests. Hopefully, I can find something. Okay, thank you.
Hi, my name is Nita Durand, and about 2009, I was diagnosed with lung cancer, and it was the same old small cell lung cancer. And we've treated it with Tarceva, we've done chemotherapy, we've done all these different kinds of things, not any of which worked except for the Tarceva, I'll tell you. So now it's the cancer has moved from my lungs to my brain, and this is leptomeningeal carcinoma. And it's a little bit harder to treat this. And if we didn't want to do intrathecal, we could radiate the whole brain. That's another alternative. So we're kind of on the edge of this thing right now. Thank you.
Back of the room, red couch, tan couch. Oh, there you go.
I'm Joan Fong. I have stage 4 lung, large non-small cell. It was diagnosed in October of 2013.
Hi, I'm Linda Musial from San Diego, and to the new kid on the block down there at the end, you're in the right place. You'll feel much better being part of this group. Fabulous group. Our daughter was diagnosed. Our daughter was diagnosed with stage 4 lung cancer in November of 2009, and she's been on different chemo treatments. And right now she's holding her own and feeling good. She's gone back to teaching full-time, single mom of a 7-year-old boy.
I'm Athena Pavusco, and I was diagnosed December of 2012, non-small cell, stage 4, and all I've been on is Tarceva, and it's been working for me.
I'm Lisa. I was diagnosed in January of this year with non-small cell stage 4. I'm ROS1, and I think that's all.
Hi, I'm Molly Golbin, and I was diagnosed in November of 2013. It's non-small cell lung cancer adenocarcinoma. I'm EGFR positive, and I've been on Tarceva since December 7th. And my last scan showed that the tumor is continuing to shrink, and I'm hoping it goes even further down in August. Thanks.
I'm her husband.
Just like to say, my name is Chris Karlovich. I work for a biopharmaceutical company, Clovis Oncology. We have a drug for non-small cell lung cancer for EGFR mutant positive patients. Many of you may be familiar with it. I'm just humbled to be here. Thanks.
Hi, I'm Valerie Brosdahl. I was diagnosed in August of 2013, stage 4 non-small cell lung cancer adenocarcinoma.
Is everybody good? That is the fastest we have ever done that.
Bonnie, 10-year lung cancer survivor. Stage 3B.
So I know people will be kind of creeping in as this goes on, and I think somebody's handling chairs. And I don't know if I said hello to everybody online yet. Did I? I said welcome everyone, and that always means you. I just wanted to make sure. So with that, we're gonna start the speaker presentation tonight with a video. Doctors Gandara and Heifetz were kind enough to let us come up and film a couple of months ago a very unique relationship that their hospitals have. So what we're going to be talking about tonight is multidisciplinary care and virtual tumor boards. So with that, Rocky, will you cue the video?
80% of all cancer patients are treated in the community center environment. It's bad enough to be diagnosed with cancer and then to have to travel 100 miles a week for treatment. That's unacceptable, really, for a patient that's that sick.
Not everybody is going to live in a big city where there is highly specialized care, but you can bring state-of-the-art care, clinical trials therapy to patients regardless of where they are.
We're a very small hospital out here in Lake Tahoe. We're really tiny. And we're about an hour from a mid-sized city, Reno, and about 2 hours from the state capital in Sacramento. And when it snows, it can take a long time to get any place. The virtual tumor board allows us to meet on a regularly scheduled basis with thought leaders at an academic center. It allows community facilities, community hospitals, to present a case at an academic place within a week of making a diagnosis.
We can look at the CT scans together, we can look at the pathology together, and reach a joint decision about the best treatment for that patient. So the advantage for our community affiliate sites is this puts them in contact directly with specialists every day of the week.
The benefit to the physician to participating in a virtual tumor board is the sense of security that he or she is doing the right thing and is as close to the cutting edge as possible.
In general, we do tell our patients, I'm going to present your case to the tumor board. Patients like that because then they say, oh, you get 20 opinions for the price of one. All the different specialists get to weigh in on the problem.
The patient is able to know that the best is available to them no matter where they go. These tumor boards have allowed me to feel better about what I do. And if I feel better about what I'm doing, the patients are going to get better care.
Lung cancer is a global epidemic and it needs a global effort. But before we can put together a global effort, we have to put the technology together where we can actually all communicate with each other. We can't have a hospital on every corner. We can't have an amazing thought leader and an amazing oncologist on every corner, but we can bring them all together with technology. And who's the benefit? Who benefits from this? The patient.
It's a great video, right? We're really excited about it. So you guys know that, and we've talked about it a lot in here and with some of you one-on-one, and some of you here are seen in academic centers and some of you in the community setting. And what we kind of want to talk about today is one of our initiatives, as you guys are aware, is our Community Hospital Center of Excellence program. So it's taking these community centers and aligning them. One aspect of the program is to align them with academic centers. And you heard Dr. Heifetz talk a little bit about, what the benefit of that is to him and his smaller community hospital up in Truckee, to be able to work with Dr. Gandara and his team down at UC Davis. So I guess the first question that I'd like to pose to kind of get the conversation started is, first of all, before we even talk about the virtual tumor board, what is a tumor board?
Okay, so I like to engage the audience. So let me see by show of hands, how many of you know what tumor boards are? Raise your hand. Okay. So I'm not surprised. This is a very sophisticated audience. How many of you have been here before to this living room? All right, so everybody knows this. The nice thing about this living room, because I gave one of the very first presentations, is that it has grown to be basically a global event. And I've been told that people from over 140 countries have joined this live webcast and been able to ask questions and so forth. So the reason I think that's important is Bonnie said that lung cancer is a global disease. So if we want to talk about communication and educating patients and also educating physicians and sharing knowledge, we need to think globally. Now, in the United States, we've done this for a long time in hospitals and clinics by tumor boards where all the different specialties for that cancer, whether it's lung cancer or breast cancer or colon cancer, they meet on a regular basis and they talk about cases and they come to a consensus about what to do. Most of you have heard the term that medicine is an art and not a science, and that really is true, because very often there's not a clear-cut answer. And so we discuss this with our surgeons and radiation oncologists and radiologists, because a lot of times the interpretation of the scan is the most important thing, and we reach a consensus. So that tumor board is well established. It's the virtual tumor board which is newer.
Very new.
My understanding of tumor boards is that they were created after the Second World War, when doctors just started to be able to approach cancer patients and try to figure out, what do I do now, boss? And they created this model where doctors from different specialties would get together. There weren't any oncologists in the 50s. There weren't. They would just get together with a surgeon, a primary care physician, a pathologist, a radiologist, and close the door. And this is the important part. They closed the door. They created a safe room where a doctor could say, I don't know what to do. Or another doctor could say, why did you do that? Why didn't you do this? And they can say that without anybody else participating in there. Without that safety, without the capacity for the doctors to be completely honest with their own feelings and their own intellectual deficits or surpluses, the tumor boards would not have taken off. They became so valuable that it's now a necessary element for accreditation from the American College of Surgeons Commission on Cancer. Academic centers like David's are able to have disease-specific tumor boards where once a week there's breast, colon, lung, urology, gynecology, hematology, and other tumor boards. Something that's less frequent, like brain tumors and melanomas, may be every other week. Community centers, like community centers down the street right here in your neighborhood, maybe have one tumor board a week for all cancers. Maybe if they're big enough, they'll have disease-specific tumor boards for a couple of cancers, and then a general tumor board. But the value of having that safe room is immeasurable. It's allowed us to be able to really help each other. And docs, when they're together, like to be able to say, hey, I really don't know what I'm supposed to do.
I'd love to comment a little bit on what Larry said. Years ago, I don't know if you remember this, I met you, I think, in a UCSF meeting up there with David Joblons, and we're talking now probably 8 years ago. And I invited Larry to be part of our team. And you said to me, I don't know why you want me on your team. And here he is today, a very, very important part of our team. 80% of cancer patients are seen in community hospitals, and they need to get the same treatment that many of you in this room are getting today from David Gandara and some other major facilities. So Larry has done an amazing job aligning himself with Dr. Gandara.
Can I make a comment?
Yes.
So Larry's also a modest guy. There's a famous saying my wife likes that, you know, you didn't just fall off the turnip truck. And so Larry didn't just fall off the turnip truck. In other words, he is at Tahoe for us now, and he's built a fabulous community cancer center there, which is state-of-the-art. But before that, he was at Cedars-Sinai. Most of you have heard of it, in Los Angeles, and was the head of the program there. So he has tremendous expertise. And it doesn't matter if he's on the turnip truck or not, he knows what he's talking about.
Thanks, guys. Thanks.
Well, and I think that's a good point, because I think Larry has the benefit of both, right? Working in academia and in the community setting. And I think that it's one of our, I don't want to say challenges, but when we're out there talking to these community centers and trying to kind of get them on board with this type of a partnership, they don't this is all they know, right, is them in their community space. So it's a little bit more challenging sometimes to get those docs to understand what the benefit really is, you know, so.
Well, you know, just a few weeks ago, there was a huge meeting in Chicago, and it's called ASCO. And everything new in every cancer is discussed over a 4-day period. That information takes way too long to trickle down to the community level. So our goal here with this program and supporting these two amazing people is to get this type of treatment that they'll discuss in just a minute to every patient in the United States. Every single patient needs to know that where they're going to receive treatment is absolutely the best.
Another question that I get in talking with patients all the time is, can they request tumor board? And how do you guys choose which cases you're bringing to tumor board?
It is 100% appreciated by every single patient when you say, I really want to get a second opinion. I want to get 20 opinions next week at the tumor board. But then we have more than one patient a week. And there's only so many slots on a tumor board. So when we've discussed certain cases and we get good at it, and when we have a situation where the community oncologist has created a cultural shift where every day he's at a tumor board, he or she is at a tumor board, the knowledge degradation of you don't use it or lose it decreases. So like in electronics over here, the signal strength to distance, the degradation over time stays high. There's less degradation because we're doing it all the time, because we're participating. So there's no need to present every case. There's no need to present every case. We only present those cases that we have problems with. Or if patients specifically say, hey, you know, I came all the way up to Truckee from Reno or someplace else because of your UC Davis connection and that tumor board, and I want to be on. And you got it, boss. You're on, okay? So a lot of people really sense the value of this communication relationship and a transparent relationship between their community doc and the thought leaders.
Dr. Gandara, can you give us an example of a recent virtual tumor board of a patient? Obviously, you're not going to name names or anything like that. That Larry brought to you, and you had a consensus of a treatment.
Right. So this basically happens every day, and I'm not sure how much you could appreciate it from the video. But UC Davis has 5 satellites or affiliates. These are people, it's not just people that are our friends and so forth. These are people that are academically or financially connected with us, and it's all the way down to Bakersfield, Merced, Marysville, Truckee. So we can see the other people, and this is bi-directional. So if we present a case, we may ask Larry, well, Larry, what do you think here? You know, if you saw this patient in the community, what would you do? So that's one thing, is it's bi-directional. It's not just the academic center preaching, you know, to the community. We can also see everything at the same time, the scans. And we have expert radiologists that are interpreting these scans, and maybe something new comes up out of that. So a case that Larry and his colleagues recently sent to us is a patient who I think really benefited from the tumor board, because it was not so much what should we do, but it was where should we go to get a biopsy? We need a piece of tissue for molecular testing. So one additional aspect of a tumor board or a virtual tumor board is not just a treatment decision making, but it's called a molecular tumor board. And almost maybe 30% of our cases now, some of you in the room have been presented at that tumor board, and some of you I know on the webcast have. The purpose is to get all the specialists together and say, do we need a biopsy? If so, where do we go? We have a pulmonologist, he could do bronchoscopy. We have a radiologist, they could do a needle biopsy. We have a surgeon, etc. So how should we get the biopsy? So Larry recently sent us a case with his colleagues up there where we knew there was an EGFR mutation in that cancer. And I just want to make one thing. I like to tell my patients, you do not have the mutation.
Right.
Your cancer has the mutation.
Right.
You know,
That's
it's not like you're an alien who flew in, you know, in a UFO and you're mutant. And so doctors do this all the time. It really burns me up. This patient is mutated. They're not mutated. Their cancer is mutated. So anyway, that's just a small thing. In this case, though, the cancer was mutated, and now the patient had erlotinib, also known as Tarceva, and now the patient had finally progressed, and we needed to know why, because there are multiple reasons, including PI3 kinase mutation that could be an explanation in that case, T790M, high MET expression, et cetera, et cetera. So we wanted to rebiopsy the patient. In this patient, we found a T790M resistance mutation, and we were able to put the patient on a clinical trial for that. One of you, I think, who's on the webcast today just underwent a biopsy 2 days ago, and that's why you aren't here physically. And this was for the ROS1 abnormality. So, you know, this can help us in multiple ways. I'm sorry for taking so long, but I think this is an important message, not only for diagnosis and treatment, but for molecular testing.
Absolutely.
So a question just came in from online. The patient wants to know if you allow patients to participate or sit in while their case is being discussed. And if you don't, do you know of any programs that do?
Absolutely not. No patients, no brothers of patients, no husbands of patients, no relatives, no sneaky little hospital administrator who might be, no hidden microphones, nothing. You do that, you blow the whole experience. You can't imagine how protective doctors are when a patient is hearing stuff. Protective of the patient and guarded. We want to have an unguarded, safe conversation. So I've never been in a hospital setting I've been in a lot of hospitals in the United States where that rule has changed. where it's been broken. So sorry, it's not allowed.
So I agree with Larry, but I will make one caveat, because many of you are saying, well, if you can't go to the tumor board, how do you gain that experience? So we have what we call at UC Davis patient or family conferences, where we will meet with the patient, either inpatient if they're in the hospital or outpatient, and we will bring in the different specialties so that we can jointly discuss with the patient and the family why we're recommending certain things, why we're not recommending other things, and to formulate a plan. So that's our way of communicating in a multi-specialty way with the patient and their families. But I agree with Larry, in the tumor board, it's really to have an unbiased opinion. You know, with all due respect, sometimes if the patient is in the room, people will say things to please the patient. You know what I'm saying? Instead of what they really think is the best thing for that patient. So that's the reason, again, as Larry said.
Right.
At what juncture in a tumor board or outside of the tumor board would you suggest a second biopsy?
So one thing that some of you I know about is our organization, the International Association for the Study of Lung Cancer, actually joined the College of American Pathology and other groups in last year in formulating guidelines to tell doctors about that, and patients can access this material too. So the guidelines say that every patient right now with lung cancer that has an adenocarcinoma component should be tested. But maybe a little later I'll talk about the master protocol where we're going to do the same thing in squamous cell. But that's at the beginning. And that's because adenocarcinoma has the most of what we call oncogenes, those mutations that drive the cancer. The guidelines now say that if that patient has had the targeted agent, this could be like for ALK or for ROS or for EGFR, and they've responded and later they progress, you need to rebiopsy them. And this is one of the most common things that we see, is that community oncologists a lot of times are not aware of this. They're not aware that that cancer is like those birds in the Galapagos that Darwin wrote about. And if there is pressure on them from, let's say, a drug, the cancer will find some way to change itself, like a chameleon. And when you rebiopsy, you may find something new that needs a different sort of treatment. So this is very, very common. Also, one of the educational points is you can't do bone biopsies for molecular testing. It's a waste of time because you have to decalcify, get rid of the bone. So I just saw a patient this past week where the patient came in and said, gee, you know, they rebiopsied me and it was inconclusive. And I said, well, you know, it's because they biopsied bone. And I examined her and I said, here's a big node sitting right here, a lymph node. This is like a piece of cake. I could take a biopsy of this myself, I wouldn't. But at any rate, I said, that's where they should go for your next biopsy, though this is very common.
Does anybody have any questions about, go ahead, Molly.
So it's interesting what you said about the cancer cells morphing or changing after treatment. So is it common for after chemotherapy that the dangerous cells sort of survive, the bad ones survive after the chemo? The chemo takes care of the easy cancer cells, and then the tough ones sort of linger on because they've learned to adapt, you know, with lesser, I guess, nutrition or oxygen or blood supply. Is that the same? Do you see the same thing for like patients that take Tarceva? Those
yes,
tough cells.
The data are strongest for this happening in patients with the oncogenes in their cancer like ALK or EGFR, so like Tarceva. Although this undoubtedly does happen in some patients getting chemotherapy, we don't have as strong markers for chemotherapy as we do for these oncogenes. So I think, how many of you in the room were here when I came last year and I talked about who's driving the bus? Were you? Okay, so So these people are all experts on this. So that talk was about how do you talk to patients about, and their families about cancer genetics. And the analogy I used for this is that you're on a bus with 40 other people and there's a driver of the bus. That's the oncogene. It's driving your cancer. You drive along for a few hours, the bus stops, the driver gets off. A new driver takes its place. That's the second driver. I also talked about maybe there's a backseat driver. That's another gene telling the driver what to do. So it's very easy to conceptualize then how a cancer could change over time. And in fact, as Darwin would have predicted, it's what we should expect. It should not surprise us. So yes, this is a really critical area.
Doctors, many people don't get biopsies because of the danger involved. They don't want to do it for some reason. How close are we to liquid biopsies?
That's a great question, and it shows that you're a man in the know, because otherwise you wouldn't know the term liquid biopsies. So that's pretty techie. So what the question is we can sample the tumor, but maybe it's in the liver or the brain or somewhere that you don't want to go in and do a biopsy. Can you gain the same information from the blood? And Wells and I were talking about this earlier, and the answer is in some cases, yes. So we published our first paper on this, detecting mutations in plasma, in blood. In other words, it's not a cell out in the blood. When cells die, they release their DNA. So all of us in the room, we have DNA in our blood. Hopefully it's normal DNA. But if you have a mutated cancer, that DNA gets shed into the blood too, and we can detect it. We've published our first paper on this in 2004. So we were one of the leaders in this. Now it is becoming it's not standard of care yet, but it's part of many clinical trials, and we are proposing that it be done in some situations. I'll give you the example. Somebody that Bonnie knows very well, because this person received the Addario Lectureship Award at our International Lung Cancer Congress last year, Tony Mok from Hong Kong. He did a groundbreaking study where he took a group of patients that had EGFR mutations in their cancer, and they were getting, I hate to say Tarceva, we're not supposed to use the brand name, so I'll say erlotinib. They were getting erlotinib, and at the end of 3 months, even if they were responding by CT scan, if they still had the mutation in the blood, they relapsed right away. If the erlotinib had eliminated the plasma mutation, meaning that it had taken care of most of the cells, and therefore it wasn't showing up in the blood again, they did very well. So now we have a new algorithm we're proposing called switch therapy, where we would actually monitor patients and be able to change their therapy ahead of time, because this would be like a red light saying, this patient's not going to do as well as most of them will. So yeah, liquid biopsies, plasma DNA, we can now, believe it or not, in a research setting, do so-called next-generation sequencing on plasma. So most of you know about Foundation Medicine, Response Genetics, how they can assay 50 genes or 250 genes. In a research basis, we're now doing that on blood. And so that's maybe the next step.
David, when you were here a year ago, you asked the audience, how many different kinds of lung cancer are there? You might ask that again, because this is a fairly new audience.
I think, Bonnie, you're underestimating this group. So play along. So how many different kinds of lung cancer are there? Some people just shout out some ideas. I know.
That's right.
So you have a great memory. So the answer, if you didn't hear it, is as many people as are here that have lung cancer. And the whole point of this is now, with this explosion of knowledge about the genetics or genomics of lung cancer, again, the way I describe it to patients is I say, it's like a fingerprint. You know, everybody's fingerprint is different. In this case, it's a molecular fingerprint. Your fingerprint is different from the next patient's. That's the whole reason that we're moving toward personalized therapy.
So now think about your community oncologist who may be taking care of 50% of you, I'm going to say probably statistically 80% of you, and 20% of you would be taken care of at an academic center. And the same complex genetic changes and unpronounceable new drugs exist for all of our cancers. All of our cancers. Instead of being an expert in one cancer, the community doc has to understand all of these cancers. So the new information comes out of ASCO last month in June. If you don't use it, you lose it. So if you're not thinking about this and hearing this all the time, practice changing discoveries. The results of clinical trials go to the background and you start doing yesterday's therapy quickly. There are about 20 different large groups of body parts that have the name cancer associated with it. 4 of them, 20% of those 20, make up 80% of all cancers. Okay? It's the 80-20 rule of life. 20% of the members of your company do 80% of the work. 20% of the kids in the class get 80% of the work done. It's a classic. It exists biologically. So those 4 cancers are breast cancer, lung cancer, prostate cancer, and colon cancer. If you have a situation where, if you create a situation where a community doctor changes the culture and goes to lunch every day instead of at his desk, but in a virtual tumor board situation, makes no excuses, I don't have time for lunch, I got to see patients during lunch. No, everybody eats lunch. Makes no excuses, and actually does that, things change. And the capacity to stay abreast of the new language that David was just talking about becomes part of your everyday experience. And that should, we haven't been able to prove it yet, but it's logical that it should increase the quality of care at your community facility. And that is the goal of this project that we're putting together.
Lisa, there's a bunch of questions. Lisa.
So I'm a little embarrassed to admit that I don't even know if my tumor was seen by a tumor board initially, because when I was diagnosed, it was chaos the first few weeks. And it sounds like from what I've heard tonight that the next opportunity to have my history submitted to a tumor board would be at the next biopsy. So my question is there, that's my question, is there any value now, I'm sort of midstream in the chemo treatment, to ask my doctor to go to a tumor board?
There's a time, you said midstream, there's a time, we have this tradition. You start some medicine for a disease. You try to measure the disease. You start some medicine, ABC, whatever it is, for all cancers. And then after 1, 2, or 3 cycles of therapy, at some defined time, assuming the patient's doing fine, you take a sanity check. A sanity check. You want to see, are things better, worse, or the same? At that time, when you do the follow-up PET scan, CAT scan, MRI, whatever the test is, blood test, whatever it is, that's the time when the community doc can present the case to a tumor board. At that time.
I might add that when I was here last year, one of the other analogies that I used is forks in the road. So a cancer patient goes through this long journey of therapy with their cancer, and periodically there's a fork in the road. In other words, something's happened. The cancer may not be responding anymore, there may be some new symptom, whatever it is, and the doctor could go this way, or this way, or this way. Those crossroads are ideal times for presenting a case to a tumor board. because that's where the physician, no matter how smart he is or how much of an expert, he can benefit from other people giving comments and their opinions about what's to be done. It could be, should we do another biopsy? You know, it could be, should this patient go on a clinical trial or should they get some second-line therapy? You said your cancer was ROS1 positive, and was that found at the beginning or only now?
It was found at the beginning, but a few weeks after they started chemo. So they started chemo in the hospital 2 days after my biopsy, and they found the ROS1 mutation a few weeks later.
And that's a very common scenario because it takes some time to get the molecular testing back. And so very often, we know that chemotherapy will benefit a lot of patients. It is not wrong to start chemotherapy while you're waiting on the test. If the patient's doing great, they're still working full time, you know, there's no pressure, of course, then you can wait and get the test back. But in your particular case, hats off to the oncologist that they did this one, because this one's not even in the guidelines. The two that are in the guidelines are EGFR mutation and ALK fusion. 2 years from now, there may be several in the guidelines, but this will be one of them.
I just wanted to ask a quick question. How do you know when it's time as a patient to switch your doctor?
What was the question? How
do you know when to switch docs?
Oh, yeah.
Boy, that's a really good question.
What's the best way of doing it?
Well, I would say when you lose faith in the doctor, when you feel that the doctor is not being transparent enough, is not being honest enough, is not spending enough time answering your questions. But your side of the equation has to be that you've done your part of your homework as well, that you participate in the groups, the therapeutic groups that exist among the cancer patients at whatever cancer center or doctor's office you're at, that you are able to recognize when the doctor just doesn't have the answer, and somehow get a gestalt that when the doctor doesn't have the answer, that is the right answer, that he or she doesn't have the answer. Other times, some docs are just seeing too many patients, don't have any time for you, and you just feel totally uncomfortable.
I agree with everything that Larry has said. I do think also that the doctor-patient relationship is a partnership. It's not a one-way street. So the biggest way that a patient, or the most common way that a patient can turn off that oncologist, is by not being engaged. In other words, you need to be engaged. You need to learn as much about your cancer as possible, and you need to question the doctor. My patients question me all the time. I don't feel bad when I have to tell people, and some of you in the room know this, when I tell them I don't know what the answer is to that. And sometimes I'll say, you know, I have a colleague in such and such a city who's an expert in this. I'll give him a ring or an email or whatever, and I'll find out. Sometimes I'll say, nobody knows this. Well, if that patient said, I'm going to another doctor, then I would feel bad for them. But, you know, when you say, should you switch doctors, sometimes it's like, when should you switch patients? Because I have had some patients that I have to just say, I'm sorry, but I cannot take care of you anymore. And it's not abandonment. I always make sure they have another oncologist. But, you know, doctor shopping is very common these days. And I have one patient who probably has seen 20 oncologists around the country. And you know, when I said there's not always a right answer, there's not always a right answer. So she has 20 oncologists and she has 15 opinions. And she comes back and she said, well, Dr. So-and-so down at MD Anderson recommended that you should do this. I said, great, why don't you go see Dr. So-and-so? So, you know, again, the oncologist also has to do what he feels is right. And so sometimes you're going to have a difference of opinion. And maybe your oncologist needs some education on a point, but also, you know, most oncologists, you know, they could be dermatologists or radiologists or anesthesiologists. Being an oncologist is not easy. And so they chose this profession because they want to help cancer patients. So I think you have to realize that too, is that this is not like punching a clock, like a lot of other specialties.
And I just want to add on to what Dr. Gandara said, is that because I know a lot of patients will come to us because they're unhappy where they are, right? And they're looking for referrals. And they know that we work with the best of the best and the people that are specializing in this disease. And I guess sometimes, what it boils down to, and what you just said, Dr. Gandara, about 20 doctors, 15 different opinions, it's because sometimes there is more than one answer. There is more than one right way to treat this right now, right? And so that's, I think, what gets really confusing for patients when they're hearing 15 different things from 15 different doctors. It makes the journey even that much more difficult, right?
Yes, yes. And I agree with everything everyone has said, but I also believe that it's up to you to educate yourself, just as you would educate yourself young when you're off to college and you're deciding you want to be an engineer. You have to learn about everything, all about engineering. Empowered patients live longer. Just tonight by sitting here, you're educating yourselves, and you've got more questions to ask your doctor the next time you see your doctor. So you have to empower yourselves.
Two things happen when patients get empowered and educated. The sense of control increases, the anxiety decreases. It decreases anxiety to know, well, I've got this, and this is what I'm going to do, and this is what we're going to do. If you decrease anxiety, there are a lot of studies out there showing that you actually can improve responses. You actually can improve survival. So stress reduction is very, very important. So that requires being an active patient instead of an active partner instead of a passive patient.
Okay, can I just add one thing, is that there is also a little bit different model that I do very commonly. Some of you in the room know that for many patients, just because of distance or their insurance or whatever, they're not going to come see me for treatment, but they come to see me periodically every few months after their new scan, whatever. And I give them my opinion about what's going on, and I send a letter back to their oncologist or talk to them on the phone. And I tell my patients, I can't tell your oncologist what to do, but I can tell them my assessment and make a recommendation, and then we can discuss it. And there are a lot of oncologists who love this model, and it's for the reason that Larry mentioned, is that if you're a general oncologist and you're seeing 28 different kinds of cancer, you can't know everything about lung cancer or breast cancer. Larry knows like 100 times more than I do about breast cancer, right? But so that's another model, and most insurance...
Not possible. David knows more about everything, I want to promise you that.
Most oncologists feel comfortable with that, and most insurance will pay for patients to come back periodically for a consultant.
So when a patient asks for a second opinion, a good oncologist will sense that and actually volunteer it before the patient actually has to ask. At those transition times, a really good doc will say, I know you can be anxious about this. Let's get a second opinion. But let's get a second opinion from somebody whose opinion I care about, not your next door neighbor's brother who happens to be on working at some biotech firm, or something you've heard about from one of your friends. Let's get an opinion from somebody that I respect. That's one thing. And then I'm the pitcher, he's the catcher. And it always works like that. You send the patient to a thought leader. We've got great places in Northern California. We've got 3. We've got 3. For lung cancer, we've got UC Davis, UC San Francisco, and Stanford. There are a lot of other great hospitals, but there's no reason to have to go any farther than those 3 for those second opinions. That's a smart second opinion. If your doctor is reluctant to do that, or you actually are worried about hurting his or her feelings, then that's your sign. You need to get a second opinion. You shouldn't have to worry about us. We're pretty battle-scarred. If the doctor says, well, why would you want to do that to me? He or she is a punk. He or she has only been in practice 3 years and they're insecure. Okay, they're not secure enough to say, I don't know. Okay? Okay. Oh, and the last thing is, I promise you though, on the flip side of this second opinioning deal, a patient, you can take this to the bank, a patient will always find a doctor to agree with what they want to hear, to tell them what they want to hear. That's 100%. And if you're dumb enough to need to do that, you're making a serious mistake.
Thank you. And I have one more question, and I know Danielle's got a lot of questions from patients inside and outside. When in the treatment program do clinical trials come into place? And how do we deal with the fact that, for the most part, community hospitals don't perform clinical trials?
Well, our enrollment in clinical trials went from 0 to a significant number because of this virtual tumor board project, because every single case, somebody in the room says, do we have a trial? And somebody's got the book out or the computer, and somebody in the room is figuring out if this patient that we're presenting qualifies for a trial. And the trials are always in our minds. So the question was, how do we do it? By the educational, well...
When in the process is it important to talk to patients about a clinical trial?
That's a hard call.
Thank you.
Day one.
Thank you.
So...
Talk about the clinical trial, and now more of your patients are participating in it. Is it virtual in nature that most of their treatment can be done in Tahoe and Truckee at the hospital? Or do they still have the burden to go to either Davis or...
It varies with the trial. It varies with the trial. If it's a phase 1 trial with a new drug, they all have to be done at the research center. If it's a phase 2 trial or phase 3 trial, most of them can be done locally. The whole point is to be able to have an infrastructure that's designed to deliver on that. And I'm sure all of the hospitals here in the peninsula, I guess most of you guys are from this neighborhood, within 50 miles of this spot. I would imagine almost all of the hospitals have clinical trials programs. They've got research coordinators and all of that ready to roll.
Right, but 80% of the people you said before are at community hospitals.
Yeah, I meant the community docs.
Okay, but they live in Boise, Idaho, or some other, Covad, Nebraska, or Truckee,
okay.
or that
Right.
there. So is there provision being made to be able to have at least most, if not all, of the trial participation at Truckee or some other location, so it helps not to preclude a lot of people's participation in trials?
So can I just, a couple of general comments. One is that out of every specialty in medicine, oncology changes the most rapidly. And in any one of these cancer types, what was the standard of care last year is different this year. All of those changes occur because of clinical trials. Without the clinical trials, there would be no change. We'd still be doing what we were doing 30 years ago. Kaiser did a very important study in breast cancer where they took patients at Kaiser who were on clinical trials, and then they looked at people who were matched, same age, everything else, and were getting the very same treatment, but outside of a clinical trial. And the patients who were on the clinical trial did better in every way. They lived longer, their quality of life is longer, et cetera, or it's better. And the reason is because clinical trials are structured for safety and efficacy and monitoring in a way that people don't typically do in their practice. So it is more work. If your oncologist doesn't believe in clinical trials, he is an outlier. So it's just like the second opinion
That's right.
thing. If your oncologist says you shouldn't get a second opinion, that is very unusual. I'll just give you one example. How many of you have ever heard of the Lung Master Protocol? So just really very few people. Okay, so this, we hope, is going to revolutionize the way we do clinical trials and new drug development and finding that molecular target. We've spent the last year and a half, it's a partnership that's never been anything like this. It's a partnership between the National Cancer Institute and 500 sites around the country. academic centers, community centers, very small places, to do what's called next generation sequencing, looking at 260 genes in patients with squamous cell lung cancer, and then be able to place the patient into a new drug targeted against that abnormality. So PI3 kinase mutation is one of those abnormalities that was mentioned earlier. There are a whole variety of them, and we have picked 5 of these abnormalities to start. And if the patient doesn't match one of those, their testing doesn't match, they get to have a PD-L1 drug, which is the new immunotherapy that's so hot. So it's really a very unique thing. It's going to be in almost every community hospital in the country. So that's the new model. And we have, it's a partnership also with the FDA. The FDA has joined us and said, if your drug works out in this, we're going to approve it. Up front, they've said that. Mm-hmm. It's a partnership with the foundation of the NIH, because pharmaceutical companies all around the country are putting money into the project so we can pay for all the extra things that you wouldn't do in routine practice. And the various sites, whether it's community or academic, won't lose money by doing the trial. So that's one thing, but it's being looked at all around the world, is looking at this, because if we're successful, this is a game changer, and it's going to change the percentage of patients going into clinical trials. Most of you know that adult cancer patients, 3 to 5% only go in the trials. That's horrible. Pediatric cancer patients, it's 70%. So the pediatricians have been able to overcome this. We need to make a system that works for community oncologists so that they can offer their patients these new treatments at home without having to travel.
You know, I was always trying to figure out why the statistics are so heavily weighted in favor of pediatrics. And I think it's I never have a day go by where another doctor comes up to me and says, Larry, I don't know how you can do what you do. But I don't know how a pediatric oncologist can do their job. So it is so emotionally impossible to be a pediatric oncologist that I believe there's a certain amount of regimented thinking that allows them to just put everybody in trials and just do it, and not too much arguing goes on from the parents of those kids. As we grow older, there's more life experience that happens, and we kind of back away from pushing it on all on the adults. Plus, there's not always a trial for every case. There actually are situations where we have a shameful paucity of meaningful trials for many cancer patients. Lung cancer is loaded with new trials now, loaded with new trials. We didn't have those new trials for lung cancer years ago. But for pediatrics, I think it's because it's just too hard to be a pediatric oncologist to do anything but stick to a trial. And it's paid off. It's paid off.
You know, one thing, David, you didn't say was one, you were partnering with advocacy organizations as well. Hello.
I'm sorry, I forgot that.
You know, but
Bonnie will always remind you of these
exactly.
things.
But beyond that, you know, this is a trial. I think this will resonate with everybody in the room and everybody online. The old way of doing trials was to find a drug first and then accrue patients to see if the drug worked on the patients. This trial starts with the patient, does their genomic sequencing, finds the right drug for the right patient at the right time, and have many different cohorts in this trial. This is revolutionary, it's game-changing, and it's going to be, you know, the future of clinical trials.
Thank you.
So I have a question. My wife has been on Tarceva for many years, like 3+. And is she a candidate for a clinical trial? I mean, she's been no evidence of disease for 3 years.
You know, when Larry said that we have all sorts of clinical trials, there's no more prominent part of lung cancer than EGFR mutated. So if it's an EGFR mutated cancer, and that's the reason that she's on Tarceva, that is where everything we've talked about comes full circle. There's a need to rebiopsy. There are clinical trials now with drugs that are highly, highly effective. And we need to find out why that cancer has become resistant to erlotinib, also known as Tarceva, in order to figure out which of those directions to go. So,
but I
prime
think you said
candidate.
his wife has no evidence of disease right now. Right. So that's interesting. If there's no evidence of disease, who in his right mind would mess with that? Okay.
No, this is when the cancer becomes resistant. Yeah, let me clarify that.
Right,
It's when the cancer becomes resistant. I have a lot of patients like that. They say, okay, we heard you say about rebiopsy. I want my rebiopsy. And I'll tell them, well, you know, you're in remission. Just what Larry was saying. I said, right now there's nothing to biopsy. That's good. And they said, God, dog, I wanted a biopsy. You know? But you're right.
So can I ask some really basic questions? I want several. So I want to find a mutation. Is that right? That's a good thing to find a mutation?
Sometimes.
It depends.
There's bad mutations and good mutations.
Okay. And they didn't get enough tissue from me, and so I went back to try to do another biopsy after my last CAT scan, and they told me that there was probably only a 50% chance that they could get enough tissue because my tumor had shrunk. So I wait, right?
Did you say you had stage 1?
4.
Oh, stage 4. Okay.
Yeah. So I just wait until the tumor grows again?
Yeah, sometimes we have to do that.
Okay. But I want a biopsy so that I can be tested for the various markers, right? Because at some point the chemo is going to quit working, is what you're telling me.
Yes.
So I asked David that
part I
specific
missed.
question about a patient within the last year at one of our tumor boards. And the answer that came out of the tumor board was that, you know, you don't know exactly what the biology, what the molecular makeup's going to be when it progresses until then. So if it's regressing right now, we usually don't biopsy when it's improving. It's when it's not improving is that we need that information. Did I say it right?
Yep, absolutely.
But I kind of wanted to be like proactive
No,
and
but
say, well, let's have this biopsy so that the instant it quits working, we've got plan B in place. But it doesn't seem to
Only
be.
takes 2 weeks.
Yeah, okay.
The other thing, this brings up the question that was asked before about liquid biopsies. So depending on the situation in some patients like this, and this is considered research, it's not standard of care, we will take a blood specimen and look for mutations. At UC Davis, that's part of a research protocol. And it's not something where you send it off and a week later you've got the results. We batch them because it's research and for cost, and so we do them every few months. But in somebody who's in remission, you know, if we find that you have an EGFR mutation in your blood, that means it's in your cancer. Do you see what I'm saying? So sometimes we can find it ahead of time that way.
Okay, thank you. I have a question. This goes back to when we were talking about changing doctors. I'm with an HMO, and I've been there for years, and I've had reason to believe they don't keep up on the latest, and I want to change insurance companies so I can come and see you, Dr. Gandara. We live in the area, but I'm so afraid that, because it was just a short time ago when you had an existing disease, the insurance companies wouldn't allow you to join. So the company I'm with right now is really good. Every time I want a CAT scan, brain scan, whatever, they do it. But I'm afraid if I change and let's say go to Blue Shield Blue Cross, that I just started with them and I just gave them $500 a month before or whatever, when I ask for all these, they're not going to approve them because I think everything has to be approved by them first instead of being in-house. Do you have any idea?
Yeah, so Larry may have a little different opinion, but I can tell you that the biggest war on cancer, in my opinion, is against the insurance companies. They are highly manipulative. In fact, several of them have been sued because of denying patient care for cancer patients. And how many of you have read the Grisham books, you know, about like the leukemia patient? You know the term churning. That's where they deny, and they figure by the time they ever have to say it's okay, you'll be dead, and they're not going to have to pay for it. This happens every day. Just before we started this, I was on the phone with an oncologist representing an insurance company who is notorious for denying. It doesn't matter. I could say I want the patient to have apple pie. He'd say, no, can't do it. So, you know, the worst thing for a cancer patient is to be fearful to change your insurance. I've probably had this 500 times where patients say, I'm afraid to leave X because, you know, my situation. In California, most people have the ability during open season to switch. And if you feel you're getting inadequate care, you should switch.
I think you should just do it and don't worry about it.
Can I ask you, I'm on Medicare, so...
Then you're home free.
Oh, I'm home.
Really, that's the best.
Oh, good.
Sure, you're home free. So you have to get supplemental. You want to get supplemental. That's so anyway.
Mandatory.
So
You get supplemental. You apply for your supplemental in the I think it's every October. It goes from it's October, November, December. I'm not sure, but I think that's when it happens. You get it before you drop your HMO.
Thank you.
It happens to us constantly with patients losing faith in their HMO. Let me just defend them, even though I would never work with one, but I want to defend them. There's not one statistic that shows that our patients live longer than their patients. Not one, okay? And that's very important. It's either we have bad statistical analysis or actually it really doesn't make a difference. But it sure feels different.
Every patient with cancer is an individual. You can't lump them all together like they do and say, oh, this 1,000 patients is doing just as well as that other 1,000. You know, it's like apples and oranges.
But when they can't tell which lung has the cancer, when right on the x-ray there's an R written on it and the doctor couldn't tell which lung it was in.
Let me can I make one more point?
Okay.
It doesn't matter what your insurance carrier is, whether it's Kaiser, HMO, PPO, whatever it is. There's a law in California. So how many of you in the room know about SB 37? Raise your hand. Okay, so SB 37 was passed about maybe 10 or 12 years ago. I testified before the assembly for this. About 25 other states have laws like it. It's called the Cancer Clinical Trial Law. What it says is if you're an insurance provider in the state of California and you have a cancer patient and there is a clinical trial for them that you can't provide, you are legally obligated to pay for that patient to go wherever, to UC Davis, Stanford, UCSF, wherever it might be, to get that clinical trial. You, the provider, the insurer, has to pay for the routine care costs, the scans, the labs, the doctor visits. The trial pays for everything that's research. So many patients don't know about this. I can tell you when I've talked to HMOs or physicians or other people and I say, do you know you are in violation of SB 37? Within about 48 hours, they all of a sudden approve the patient for whatever it was. So that's a very powerful tool. It's just like Bonnie said about educating yourself. If you're a cancer patient, you need to know about this because a lot of times the best treatments are on clinical trials. Just one quick other thing. A lot of patients are concerned, I don't want to go on a phase 1 trial. That means it's early. I only want to go phase 3 or something. Every one of the breakthroughs in cancer in the last 10 years have been seen in the phase 1 trials. And in fact, we have phase 1 trials now that have over 1,000 patients on them. They just keep going and going the more experience they get. So don't be afraid of those situations. And if you need a second opinion about it, go get it.
So I didn't want to step on any toes, but I have a question about the clinical trials. I've gotten the message that they can be very helpful. They're very important. When I've tried to research them, they all seem to indicate that there's sort of a sweet spot. Like I'm not eligible because I'm in the first line chemo. Can you give some guidance about, are there any pitfalls to be careful of to not take something because it might throw you out of eligibility, or a sweet spot time where you really need to be hyper aware of the opportunities that are available?
At that time, when a judgment's going to be made about whether or not you're going into a response. And we are very strict about the definition of the word response. If we can shrink it down by 50% of its measurable size, that's called a partial response or a partial remission. You can't think about going to a complete response where you can't see anything until you've gotten to a partial. At the time we do that mid-course assessment, Plan B has to already be in place. We pretty much know what we're going to do, what if. That's also time for you to be studying up where certain options might be, and you can discuss that with the doctor. Usually the doctor's nurse knows a hell of a lot more about it and has more time to talk about it. But that's possibly a time when a clinical trial becomes operational, because we have to be hopeful that the first treatment is working. You got to get behind the first treatment and expect it to work. So if it's working, you don't want to mess with the clinical trial. You want to keep going with whatever's working.
And the other thing I mentioned is a lot of times this is at that crossroad, the fork in the road. When a decision has to be made, that's when to think about a clinical trial. Clinicaltrials.gov, how many of you know about that? Okay, everybody. So this has every clinical trial in the United States for cancer by law has to be registered there. It's not really user-friendly, and it's really bizarro. We, for the master protocol, the central IRB made us take stuff off our website because they said they hadn't reviewed it and approved it yet. And yet they have this clinicaltrials.gov, which is almost uninterpretable. But that's every clinical trial. It has the basics there. What I tell patients is call the center and talk to the research nurse or the clinical coordinator. They know every minutia about the trials that they have. And a lot of times we know what's different between our trial and, let's say, a trial at Stanford. And we'll say, you know, you're not eligible for the one here, but the one at Stanford, actually you are, or vice versa. But we don't expect a patient to know every aspect of these trials. We have 150 trials open at UC Davis. I have to go pull them up and look at them. We have 3 trials with the PD-L1 immunotherapy drugs now. Every one of them is different. And so I'll have to look in this one, this one, this one. Some of you have talked to me about this, and I'll say, well, you can't go on that one, but you can go on this one. But it's a process. And so you can't be intimidated about it. You need to find somebody who can help you.
So that's when you need to be connected to a thought leader. And one of the problems that exists is getting through the front door of the Mecca, of the big ivory tower. The great university has a barrier, a perceived barrier to getting patients in. It takes a while to get in. If you have a tumor board situation, well, okay, fine, call Bonnie. But it takes a long time to get the patient in. If you have a virtual tumor board program, we can get them in a week easily because we've already made the connection. If you get a second opinion early, for nothing more than developing a relationship, getting a patient number, knowing where a thought leader is, put that in the bank. Just put that in the bank. Now you've got a backup, be it Stanford, UCSF, UCLA, UC Davis, Sloan Kettering, MD Anderson, wherever you want. You've got it in the bank. At that point, you've got access, when there's that fork in the road, to the thought leaders. Because nobody in private practice on the corner over here of El Camino Real and some street, okay, is aware of all 150 trials for each of the thousands of cancers we've got going. The only people who know that are the thought leaders.
We have an app for iPhones and smartphones, and part of the app is our patient navigation guide and Cancer Commons, donate your data, but the other thing is Smart Patients. It's called Smart Patients, and this is software that was written by a fellow that used to work for Google Health, Ronnie Ziegler, and he has made navigating clinicaltrials.gov much simpler, much simpler.
Great.
So get on our app, download it. It's there.
It's actually on the website right now.
And it's on the website too, much easier.
If I can just add one more thing, because it's a personal thing. I've had a lot of patients say, you know, my God, I can't believe I got in to see you within a week. My doctor said, oh, if you want to see Dr. Gandara, it's going to be 3 months. Well, at UC Davis, I'm very proud of the fact that the average time for a lung cancer patient to have a new patient appointment is 8 days. And
That's 'cause
Bonnie,
Dave's in charge
no,
of the lung
Danielle
cancer part.
know that if there's an urgent patient, we prioritize it. You know, every doctor has so many clinics or a clinic a week. And so I commonly will have what's called a unique clinic. If I have an urgent patient we have to see, we do it. And so, you know, we're very proud of that fact. So, in fact, you know, if you try to see us in lung cancer, sometimes the patient says, I'm having a new scan in a month. And so I'll say, don't come to see us till after the new scan because you're doing fine and so forth. But if they need to be seen, we'll do it.
We actually have a patient over here in the corner that has an appointment with you on, I think, August 8th. And he wants to know if he should have a scan before he...
You know, I probably have to talk this over with a glass of wine because it depends on your case. And so I think we need to go through the details, but maybe we can do that when we finish.
Yeah, I know you guys in the room, there's some people I see hands going up, but I want, my online questions are piling up. Some of them we're gonna have to kind of go back a little bit. Because we were just talking about clinical trials, someone online wants to know if international patients qualify for US trials.
So this is a very complex issue. I have patients who've come to see me from Hong Kong, the Netherlands, foreign countries like Miami. Oh, they're not foreign, I guess. You know, all over. And, you know, the insurance provision around the world is so totally different from country to country that very often we need to reach out so that that trial becomes an international trial and the patient can get that trial in their country. There are a lot of countries, you probably know some of them, where basically there's no insurance. And so the wealthy people pay for their cancer care totally out of their pocket. To their benefit, many of the new drugs that are so expensive, the pharmaceutical industry has provided drug at essentially no cost in a lot of those countries, which are developing countries. So it is complex for a patient to come here. But I have patients who've come and, you know, there are patients who can provide for themselves and they go on our trials here. Because they're residents, because they're not a citizen or their residence is elsewhere, that doesn't mean they can't get on the trial. But the payment issue is a big one.
Another question, this is going back to when we were talking about biopsies, as a patient whose biopsy was taken from some brain mets, tested for ALK and EGFR, came back negative. Should they request a second biopsy from someplace else, and are there other mutations to test for?
Yeah, so what do you think, Larry?
I don't think so.
Yeah, so this is a very complex area, and the brain is the one site where there's some additional complexity. How many of you have ever heard the term brain or CNS sanctuary? Have you ever heard that term? Okay. What that means is that during evolution, presumably we all believe in evolution, I hope, the body figured out that it wasn't good to have toxins in the brain. You know, when the first humans they ate a plant, it was poisonous. So if it did something to some other part of the body, that was bad, but they didn't want it to get in the brain. So there's this barrier called the blood-brain barrier that keeps toxins out. And most drugs are considered toxins. Now, the way this relates to cancer is that, and some of you may have had experiences like this, your cancer can be in remission in the rest of your body and progress only in the brain. It doesn't mean the drug isn't working, it means it can't get in there. And so there are a lot of situations like for ALK translocated cancers where that's pretty common. That being said, if you take a biopsy of the brain metastasis, it may not tell you what's going on elsewhere because the drugs didn't have an effect. So Darwin would have said, that's the wrong place to biopsy. So it is complex. We did a survey a few years ago for 400 oncologists, and we had 10 experts, and then we had 400 practicing oncologists. And we said, if you had your choice on where to biopsy for molecular testing, would you biopsy the primary tumor, that means where it started, like in the lung, or would you biopsy a metastasis? 80% of the primary oncologists, the community oncologists, said biopsy the primary, that's where it started. 100% of the experts said biopsy the metastasis. Those are the bad actors. Those are the ones that got out and spread. So I'm just saying, you know, we don't know for sure, but the brain is a particularly difficult area. And again, depending on the situation, this is a complex question. You might need another biopsy.
Yeah. We have two more questions. Well, actually, we have many, but this one is from a patient that says they're at a place where they don't know where to go. They went to Colorado because they were told they were ALK, and this was where they should go. After Foundation 1 tested, I realized I was not ALK, but EGFR with an exon 20. No targeted therapy, now on traditional therapy. Where do they go now?
Okay, so Colorado is a good place.
Yep, for ALK.
You have to realize next generation sequencing doesn't test for these things the way the standard of care does. And I think many patients don't understand this. Next generation sequencing is fabulous for certain purposes. But the standard of care for EGFR mutation is PCR technology, and the standard of care for ALK is what's called FISH. So you go fishing. And I actually had a case earlier today where we had this discrepancy, and I had to send the patient an email about, you know, this is not exactly what you expected. So like many things in medicine, it's not a direct answer, it's complex. If they were suspected of having ALK in their cancer, again, not in the patient, but in the cancer, that meant that a test was done that showed something. It could have been what's called a false positive. And if now there's no ALK and instead there's an EGFR mutation, then that's probably more accurate because that's a PCR test. The exon 20, here's the other adage I say not all mutations are created equal. In other words, for EGFR, there are about 20 mutations. For KRAS, there are about 50. They're not all the same. And so this exon 20 is a mutation, and people say, oh, great, I got an EGFR mutation. That means erlotinib's going to work. This one is usually resistant. But there are some new drugs and strategies which can sometimes be used, but it's in clinical trials. What I tell my patients with this mutation is the most effective treatment for this is chemotherapy. And that's what they should get.
I have another question before Danielle gives you another one from a non-blind patient. Have you ever had a patient that had an EGFR mutation and then an ALK mutation, or vice versa?
No, I've not.
So this is the evolution, this is the Darwinism, and it's extraordinarily important for ALK-positive cancers. The people at Colorado, Dr. Kamage, who's spoken here at the living room, and Dr. Dobley, took a group of patients with ALK-positive cancers.
Oh, it's your mic for now.
Mics are gone?
Just
his.
And
Okay.
they treated them with the standard of care drug, which is really good, called crizotinib. That's for ALK. And they responded. And then when their cancer started regrowing, they did a repeat biopsy. And they expected, and everybody in the world expected, that they would find some patients that had a secondary mutation in ALK, or some change in the ALK gene, too much ALK or something like that, and that's why they became resistant. And they found that. But they also found patients that had lost ALK, and now they had an EGFR mutation. That's not that unusual. We have seen a couple of patients with the reverse, but it's much more rare. They saw other patients that had lost the ALK and now had a KRAS mutation, which is a whole nother thing. We'd take another hour on that one. And other things. So, and all the other, in the EGFR mutated patients, some of them had transformed to what we call small cell lung cancer. It's totally different and needs new treatment. 5 years ago, we would have said this is impossible. But in actuality, this is what Darwin or mathematical modeling people who model what happens if you put something under pressure and then something evolves out of that, this is what they would have predicted. And again, that's the reason, if there's any doubt, to do a repeat biopsy, because if a patient had an EGFR mutation and now they've got small cell lung cancer, they may need a different treatment. Larry, any comments on that?
I just haven't had enough patients to see that, and I'm totally impressed that you've been able to find that. Okay.
We've seen it in
Yeah.
our patients.
Good, just grab a mic, Doug. Thanks.
Listening to what you were saying about the blood and how, I'm not entirely clear on how this has moved around my body, but I love to exercise. I like to do strenuous exercise. Does that have any influence at all on the cancer moving around the body?
As a rule, we want you to stay as fit as you can possibly be, as fit as you can be, with the proviso that if you're doing strenuous exercise and you have something in a bone, you could hurt yourself if you do a lot of impact. But if you don't, you should be able to just be fine. However, there are certain organs that have got limits to them. Your pulmonary function, your cardiac function, I mean, you've got to get a little bit of clearance from your doc as to where your disease is to go for it. But then you should, the more exercise you do, the better. We have a program called Exercise for Energy for our patients, and they get together and they're in a gym and they go there twice a week. So we very much, it's all positive, it's all good for you.
Well, I'm so new, but so far that's the best thing to reduce the stress for me. First thing in the morning, too.
Well, you just keep doing it.
Yes. Okay.
Yeah, so I agree entirely with Larry, and I'd like to amplify on it more, because one thing that I think patients can do is engage your oncologist in what we call the whole man concept, with all deference to women. I'm just saying the whole person concept. In other words, they're not just treating your cancer with drugs, they're treating you as a person. And so all of these other aspects we haven't talked about, but they are just as important as the treatment. There are a lot of myths on the internet. At least once a week, I have patients who say, well, doc, I came in, I cut out all the sugar, because I know that's really bad for me. I'm not eating meat, I'm only eating, genetically non-modified vegetables and so forth. Well, that's all a bunch of bunko. It's total bunko. And so the things that the patient can do, because patients often say, what can I do? So number one, they can become educated, as Bonnie and Danielle said. Number two, nutrition is very important. We monitor a blood test on probably a monthly basis called albumin, where it measures the protein nutrition in the blood. It's a very good test. Any of you who are my patients, you've heard me talk about this. And if what cancer does in a lot of patients is it changes your metabolism, and you actually can't metabolize proteins the way you're supposed to, and that's why cancer patients lose muscle mass, and then you get weak and you get a pneumonia. So nutrition is very important. Exercise is very important. We want patients to continue to stay fit and as healthy. If you're in incredible pain, we understand you can't exercise, but if you're able to, we want you to do that. The other thing is psychology. Cancer is a bad thing. Nobody wants to have cancer. And very often, patients and their families need some help. And you can't think about this as a failure, like I'm not strong enough. Everybody dealing with a life-threatening situation may need some counseling, sometimes some medication, and you shouldn't feel bad to tell your oncologist that and get help when you need it. Loss of job, loss of income, sometimes family relationships get messed up because, one person is sick all the time. So, you can't underestimate, the importance of these other things. Your job. Some people say, God, one of the good things about cancer is I got to quit my job. I hated that job. And other patients, it's like, this is the only thing that's keeping me going. And I tell them, do it. If you feel up to it, work. If you can't do full-time, do half-time. But if it's important for you to maintain your quality of life, do the things that are important to you.
David and Larry, I hate to interrupt you. I think we're going to do a two-part series on this. We can make 2 videos out of this. There's no doubt about it, right, everybody? Yeah, which we'll do. But please, for the people in the room and online, they're asking about immunotherapy. How does that relate to clinical trials, standard chemotherapy, et cetera? We need to get this message to them.
Well, I mean, most of our new drugs have either a MAB or an IB associated with it. A MAB means monoclonal antibody, an IB means inhibitor. Okay. An inhibitor of a certain set of proteins within the tumor cell, or a monoclonal antibody against certain signals on the tumor cell. So a whole bunch of our medications that we use are already immunotherapeutic molecules. One of the biggest, just down the street from Genentech, is trastuzumab. Bevacizumab. Hell of a drug to say. Avastin is what it is.
See, again, the drug companies make the generic name almost impossible to pronounce, and the brand name just falls off your tongue.
And they spend billions on name figuring outing consultants, that you all pay for. So there's 2 bad guys in the equation. The insurance companies, and I gotta tell you, the drug companies are just ripping us all off. They just really are. Okay. But I know that they're funding this, so we love you too. Okay.
No, I would actually say pharma, and some of it's for obvious reasons, they have really embraced the new oncology and personalized medicine, because they realize, if you have a drug that doesn't work in everybody, and that's all of our cancer drugs, but you have a small subset where it really works good, you can make a profit and have a good ethical drug. And so I think actually, like I said, this master protocol pharma is part of. So it's not that pharma is all good, but they're not all bad.
That's true.
The insurance companies, they're all bad.
So we are applying immunotherapy today.
But 1 or 2 sentences so the patients understand the difference between immunotherapy and standard therapy.
Oh, go ahead.
Well, so what Larry was saying is true. Some drugs that you don't think of as immunotherapy, actually part of the reason they work is an immune-mediated response. So a lot of these MABs, cetuximab, bevacizumab, trastuzumab for breast cancer, part of what they do is actually inducing an immune response. It's not the primary mechanism, but it's a secondary. For the last 40 years, we've had attempts to make vaccines and other sorts of immunotherapies that were designed to boost the immune system. And although a few of them turned out to be useful, 90% of them failed. And the reason is that everybody with cancer thinks, oh, my immune system's down. If I get chemotherapy, my immune system's going to be really down. Most patients' immune system's pretty much intact. The reason that cancers don't respond to immune therapies is there is a shield there that blocks the ability of the body to recognize the cancer as foreign. So everybody's heard the term foreign body. Like if you have mesh after an operation and you have a reaction to it, it's because it's a foreign body in your body. So this, the way I explain this to my patients is like a stealth bomber. So radar can't detect the stealth bomber, and that's because it has this shield, which I can't explain. Cancers do the same thing, and the shield is called PD-L1. And a certain percentage of all the different kinds of cancers have a lot of this PD-L1. It prevents the body reacting, and it prevents your own T cells that should go in and kill that cancer cell from recognizing it. So one exciting new group of drugs are anti-PD-1, that's a relative, or PD-L1. They break down that shield and allow your body's immune system to recognize the cancer. So it's very different from the thing about, oh, we're going to boost up your immune system. This is making your body's immune system say, oh, this is a foreign thing here. It shouldn't belong here. We're going to go eat it up and kill it. So there are about 6 or 8 of these drugs being developed now. They're all a little different. We don't know exactly how to measure PD-L1, so there's a lot of controversy there. The drugs don't work on everybody. When they do work, you tend to have a very long remission for years. We have several of these trials at UC Davis. They're very specific, like the question that was asked earlier about maybe I won't qualify. A lot of patients don't qualify because they have to fit into a protocol. This master protocol that I told you about, if you don't match with anything else, you get the PD-L1 drug. But this, I think, is what Bonnie is asking about. And, you know, we don't know when one will get on the market. In other words, it could be, for lung cancer at least, it could be at least another year.
So how do because this is such a hot topic right now, and patients are asking consistently about immunotherapy, and there's 3 companies I can think of, Genentech being one of them, BMS and Merck, right? They all have something pretty decent going on in immunotherapy right now. How do you determine which one of those trials might be best for a patient, whether it's Genentech?
Boy, that's a real good question. I mean, we have every institution tries to have non-competing trials, but then the knowledge base changes. So you start with a set of trials a couple of years ago, but new stuff comes out and you're stuck with this old trial. So an ethical doc is going to say, you know, we've got this option for you, but there's another option at another institution. What you don't want to have are competing trials. So let's say for stage 2 breast cancer with certain characteristics, you've got more than one trial. That's a bad thing. You have to have it so that you can only enroll patients in a specific trial, at a specific phase. Maybe I'm wrong about that, Dave.
But isn't it true that
Can I just answer before we go on? Because I want to make this point too. And that is patients chasing hype.
Right.
This happens all the time. So the current hype is on these drugs. And although they're very exciting and they work in some patients, there are a lot of patients who forego standard treatment that is going to benefit them because they want these drugs. And it's because they've heard about it, they read about it in the Wall Street Journal, or they heard about it on the NewsHour. And so, you know, a patient also has to realize that to chase one of these things is not smart. In other words, if it's the right time and you fit in it, you know, you can go out and you can travel around the country and find one of these, but I've had patients sell their homes and move to New York to get some drug for some mutation found in their cancer by a company called Foundation Medicine, who I'm working with, but I'll tell you, they recommend all kinds of things. And, you know, the drug's never been shown to benefit a single patient. You know what I'm saying? So you have to also be smart and realize you shouldn't be chasing something when there's another good alternative for you.
One of the problems we've got is that there's no less sexy term than standard or standard therapy, traditional therapy, first line standard. But people forget that that was cutting edge just a few years ago. So there's this sense that, oh, I don't want to have the regular stuff, I want the new stuff. And that's a huge, huge, huge mistake. We need a better word.
We've also had multiple instances in the last 5 years where the new stuff was detrimental. And what I mean by that is typically the way the phase 3 trial works is you have the standard of care plus the new stuff versus the standard of care. The people who got the new stuff and the standard of care lived shorter, had more toxicity, did worse. Multiple examples. That's the reason for the master protocol. We're going to try to change the way we do business and be smarter about developing drugs. So I just want to make you aware that chasing the new thing, it's not that it's wrong, but you have to put some thought into it.
David and Larry, can I just give you my impression of immunotherapy? Normally, and you know, we all know this, you get an infection when you're little or older, and your immune system usually kicks in and takes care of it, sometimes with the help of antibiotics and other things. But for whatever reason, our immune system doesn't recognize cancer because of this shield that's around it. So, you know, it's there, and it's growing, and stuff is happening. And for a certain percentage of patients, immunotherapy drugs blow up that shield, knock it away, and the drug works. But you have to have faith in the people that are treating you to be able to explain when and where all of these different therapies make sense.
There are some cancers that are much more sensitive to immune therapy. One cancer that used to be the world's worst, now we've gotten some real responses out of, and that's called melanoma. And melanoma is now very, very, I was going to say exquisitely, but just very sensitive to super toxic immune therapy, direct immune therapy, and doesn't really respond to any chemo. So it's tumor to tumor.
Right.
Exactly.
And you know, to what David said earlier and last year, everybody that has lung cancer has a very different biology. So there are hundreds of thousands of lung cancers, and they all have to be treated uniquely.
Can I just say one thing about the diet exercise question and what you can do for yourselves? There's a woman at Ohio State. Ohio State happens to be part of the Addario Cancer Research Foundation. There's a woman at Ohio State, her name is Barbara Anderson. She's a clinical psychologist. About 8 years ago, she published an article where she had 260 women with stage 2 breast cancer who were completely matched with another 260 women for age, stage, the type of cancer, hormone receptors, all the same kind of alphabet soup that we use for lung cancer, we have for breast cancer. Half of them got seen by a clinical psychologist within the first couple of weeks of being seen. They filled out a little questionnaire, and then they got seen again a year later. The other half got stuck into cohorts of 10 patients who went every week to a meeting with clinical psychologist, with an exercise physiologist, with a nutritionist, with a financial counselor. And they did this every week for 3 months, and then they met once a month for the remainder of the year. At the end of 5 years, there was a 20% benefit in the arm that had what's called the intensive global interventions. So some of us have actually picked up on that and joined up with this Ohio State reality and are offering it to all of our patients. We don't need to be part of an experiment, just do it to all of our patients. So there's everything real about, it's not just lip service, yeah, exercise. No, we really mean it. Reduce that stress, exercise, eat properly, okay, and you get better responses.
That's multidisciplinary.
Yeah, right, really.
Right?
Does somebody else have a question before I move to online? Go ahead. We just need a mic. Yeah. Oh, we need to grab a couch mic. Yeah, there you go.
I have a question about elderly patients and your experience in elderly patients. I know a couple of people who are in their 80s and just having really poor prognoses, and I'm wondering if, and so we're getting pushback from the doctors on, well, molecular testing wouldn't really benefit. So I'm wondering what your experience is with molecular testing in elderly patients, and what are the risks and benefits to that kind of treatment?
So we have a word, it's called, what's the patient's biologic age versus chronologic age? We've seen a lot of patients in their 60s who look like they're 80, and a lot of patients in their 80s who look like they're 60. So we have to try to figure out their biologic age, not their chronologic age. And then we have to actually not practice age discrimination and say, oh, well, who wants to do this to this elderly person because we shouldn't. Well, we shouldn't. It's a function of, if our medicine is easy, of course we should give it. But there's usually not too much easy about what we do. So it's a balancing act of the risk-benefit of, because the risks really do increase. The risks of living through the side effects of some of our drugs get pretty significant as you get older. Good.
Yeah, I agree with Larry. We actually, in Southwest Oncology Group, I'm the chairman of the lung committee there, we did a trial in the past where we took patients and we gave all the patients the same treatment, and we segregated them based on were they elderly, and we define that as greater than 70, or what was their performance status. In other words, how fit were they? And what we found out is that the fit elderly did twice as good as the younger patients that were unfit. So in other words, if you have a 40-year-old patient that is bedbound because of pain and they've lost 40 pounds and so forth, they're not going to do as well as a fit 80-year-old. So as Larry said, you have to assess, maybe the 80-year-old has bad heart disease and that's going to factor in, and they're not going to do as well. But I'm saying the fit elderly do very well. I had a patient a couple of years ago who was 82, a woman, and she was pretty fit. She lived in a senior home, but she exercised, she had a group of friends and everything. And she had stage 4 adenocarcinoma. And she had seen an oncologist locally in Sacramento, and they recommended hospice. And so I saw her and I said, well, tell me about your prior history. And I said, did you smoke? And she said, yeah, I smoked for 10 years. I smoked a pack a day. And I said, well, how long ago was that? And she said, that was 50 years ago. And I said, whoa, we need to test you for EGFR mutation. She was positive. So she got erlotinib and promptly went into a complete remission, which she stayed in for the next year and a half. So again, you have to balance. Every patient's different, like we said, but we don't want to withhold good treatment or even testing, in elderly patients just because they're old.
So Lisa, I know you have a question. I just have to do a couple of logistic things for the TV people, and then we'll go back and answer some last questions for the meeting. As most of you know, this is Penn TV is here, and not only are they live streaming, but you can all come back and watch this on Channel 26, local Peninsula television, for the next 30 days. So I have to close up for TV. And by that, I just want to say thank you to everybody watching. Obviously, thank you to our generous sponsors, whom without we would not be able to have this meeting and some of our other amazing programs. We have Genentech, Lilly, BMS, Celgene, Novartis, Merck. They all make this possible. So
I take back what I said about the dark side.
So a
Larry,
big
that won't be in the edited version.
So a big thank you to them. I obviously want to thank the Office Bar and Grill for consistently donating the food every month. Obviously, a huge thank you to Peninsula Television for coming out here every month and doing what they do here with us. One thing I want to push out is the San Francisco run. After my thank yous, what?
Just thank you to Dr. Gandara and
Oh,
Dr.
well, I haven't
Heifetz.
gotten there yet. They're at the very end. Thank you the most. I want to talk a little bit about the San Francisco run, which is coming up on September 21st. It's a Sunday. We need teams. So we would love, love, love to have you guys start your own teams and come out and join us. It's an amazing day. I know I say this every month and every time I talk to you guys, but it's a great day. There's like 2,500 people out there, and it's in San Francisco. It's fun. So if you don't want to start your own team, you can always join Bonnie's Heroes.
You can join Bonnie's Heroes, and if you get online and you can't come and you can't run and you can't do anything, I have no followers yet. Really. It's so sad.
Yeah.
So, Bonnie's Heroes, get on the site. I need a couple of you to follow me.
Yeah. And she doesn't walk it or run it. She sits in the tent with wine and cheese and all kinds of really great stuff. So it is the best team to be on.
You don't have to do anything.
Yeah, yeah. So we really encourage you guys to come out for the day. It's an amazing day. Also, I know I don't normally do this, but I'm going to ask all of you to think about who you may know, who you may work for, or who you may know that works for somebody who might want to sponsor this event. It's always my super uncomfortable space asking for people to help us, but we absolutely cannot. Well, we cannot do what we do for all of you and the so many others that aren't here in this room tonight without the funding to do it. So anything you guys can do to help us with sponsorships, whether you know somebody at what, Jenny? What are we looking for? Everything. We have several people that sponsor the event, but we can always, yeah.
And just for everybody to, here and watching, we fund a lot of research around the world, nationally and internationally. We funded Dr. Gandara, and many of you have been the benefits of some of the things we funded. So as much as we love, and this is our favorite thing to do here, teaching you to go out there and get the absolute best care, we do many other things. So research is one of our key objectives.
Yeah, and I just looked around the room and realized I forgot to thank Clovis, which is terrible because they're sitting right here. So a big thank you to Clovis as well. So a couple of other things. We've got Philly coming up on October 5th. So any of you online who are watching and in Philly, same thing goes out to you. Build your Hollywood, Florida. So Memorial Cancer Institute is one of our community hospitals in Hollywood, Florida, and we're having our first time ever event out there, and it's already halfway to budget or goal, and we're really excited about that. So get online, check out our events, and we would love to see you all out there. One or all of us are at almost every event. So.
What about employer match? Match.
Yes, check to see if your employer matches your donations, and if they don't, we can sign them up and make sure that happens.
Does it.
Yes, Apple does it.
And I have to wrap.
Google does it.
I have to wrap. So I'm going to end with a very, very, very huge thank yous to Drs. Gandara and Dr. Heifetz.